Pablo Pergola, and on behalf of CME Outfitters, I would like to welcome you to today's educational activity titled Understanding Anemia in Patients with CKD, from Diagnosis to Data on Emerging Agents. Today's program is supported by an educational grant from Akivia Therapeutics Incorporated. This CME activity is brought to you by CME Outfitters, an award-winning jointly accredited provider of continuing education for clinicians worldwide. I want to encourage everyone to join us today on our live Twitter conversation at CME Outfitters. We will be monitoring the Twitter feed and responding to your tweets as they come in. One last item I want to note is that we're using an enhanced platform today that allows you to save slides, take notes on slides, answer polling questions, and send us your questions. Please look at the tabs on the left of your screen and give us your feedback on the program and the platform as well. Again, I am Pablo Pergola. I am the Research Director of Renal Associates PA in San Antonio, Texas. I'm a nephrologist. I am pleased to be joined today by two distinguished colleagues who will ask to each introduce themselves. And Dan?
Hello, I'm Dr. Daniel Coyne. I'm a professor of medicine at Washington University in St. Louis, where I'm the director of our academic dialysis unit, the Chromoy American Kidney Center.
And Bruce?
I am Bruce Spinowitz. I'm Associate Director of Nephrology and Vice Chairman of Medicine at New York Presbyterian in Queens, and I'm a Professor of Clinical Medicine at Weill Cornell Medical College. Pleased to be here this evening with all of you.
Thank you both for joining us, and it's going to be my pleasure to try to host this hopefully very engaging discussion, and hopefully our audience will finding this very rewarding. So let's begin with our first learning objective: review the pathophysiology, signs, and symptoms of anemia in patients with CKD. And this will be a brief introduction to the topic today, but first we'll do a question for our audience. So please answer this question for us. Very good. Thanks for your participation. As you can see, most of us chose the answer B, which is actually the correct answer. We'll see, hopefully, some of the background will consolidate your thoughts on that answer. So let's talk about the symptoms of anemia in CKD. And this is by no means a complete list, but it meant to list the most common ones. As you know, fatigue or tiredness are probably the most common findings, shortness of breath, unusually pale skin, weakness. They could have body aches and different pains, complain of dizziness or fainting if it's extreme. They could have tachycardia, they could have headaches, sleep problems, trouble concentrating, and one we left out here that's fairly common is a decrease in appetite. So we are familiar with these symptoms that can signal anemia and should prompt us to look into more detail into the possibility of a drop in hemoglobin. So in this slide, we're meant to show you the relationship between the stage of CKD and anemia. On the left side, the first four bar groups based on creatinine, but probably more accurate is to look at this based on GFR, and from left to right, more than 60 mLs per minute, going through 30 to 60, 15 to 30, and less than 15. As you can see, if you follow the darker blue, blackish line, the gray and the green, the incidence of anemia is significantly more common as you go down the GFR and CKD stages, with as many as 75% of the patients having anemia, depending on the definition, when they reach stage 5. And the definition here is important because if you look at guidelines, we don't define anemia as hemoglobin less than 10, but we look at anemia as hemoglobin below normal range, 12 grams per deciliter for women and 13 for men. So here, if you extended this to even 13 grams for men, those numbers would go up even more. So important as patients progress to recognize that anemia is a very frequent complication of CKD. So talking about the normal physiology of red blood cell production, I think the thing to look at here is that the items on the left and the bone marrow are those that we consider to be erythropoietin dependent type stages. And then as the red cells mature, those are steps that are iron dependent. So both adequate erythropoiesis stimulation with erythropoietin and adequate availability of iron are essential for red blood cell production and maturation. There are two main factors that contribute to anemia in CKD that most of you are familiar with, and those are erythropoietin deficiency, so no adequate amounts of EPO reaching the bone marrow to stimulate hematopoiesis, and iron deficiency. Other contributors in CKD include shortened RBC lifespan, increased blood loss, uremic toxins, and inadequate dialysis can contribute to anemia and hyperparathyroidism. We discussed that one of the important items in anemia in CKD is availability of EPO. And what we illustrate here is the amount of EPO present in patients that are either nephric or anephric. And you can see that despite a significant drop in hemoglobin, as you look at the x-axis, the amount of EPO fails to increase in the normal range. And by normal range, we mean the range that you would expect to see EPO in someone with no kidney problems. So if you had somebody became anemic for blood loss and had normal kidney function, EPO rises to attend to that blood loss and stimulate erythropoiesis. I think what's interesting here is to note that despite being anephric, patients have measurable levels of EPO, and that may become relevant as we discuss later on the HIF-PHI agents. And here we talk about availability of iron absorbed from food and in relation to serum ferritin levels, but I think more importantly, we should look at this slide in relation to hepcidin level, again, on the left axis. And we know that as hepcidin levels increase, your ability to absorb iron decreases. And we'll hear later that hepcidin is abnormally elevated in patients with CKD, and that prevents us from absorbing and mobilizing iron. So again, iron absorption is highly dependent on hepcidin levels dropping adequately to allow absorption and mobilization. And so talking about hepcidin, hepcidin is the master regulator of iron absorption and mobilization. The hepcidin is produced in the liver and its level is inhibited. Levels are decreased by iron deficiency, hypoxemia, and messaging from the bone marrow through erythroferrone to signal the need for iron in the bone marrow to attend to the increase in erythrocyte production. It can be increased by inflammation, increases in iron here more than transferrin saturation. We were talking about available iron, And so again, importantly, inflammation and iron both will increase hepcidin to regulate iron absorption and mobilization in the case of the increase of iron, but abnormally in the case of inflammation. And so the key thing here to recognize is that hepcidin regulates the levels of ferroportin, and ferroportin is the key protein that regulates the entry and exit of iron from and back into the cells, including enterocytes. So if ferroportin is not present, iron cannot move across the tissues. So again, this relationship is important because we want you to recognize that drugs that can have an effect on regulating hepcidin levels can have a significant advantage in having a much more physiological way of regulating iron and anemia, and could have, again, an advantage over individual iron replacement and EPO replacement. So we're going to open this section for your questions and faculty discussion. I have a question that relates to HIF-PHIs approved in Japan. I'm going to adjourn this question for later, because as you'll see, we'll discuss the HIF-PHIs in detail, and then we'll have an opportunity to have a conversation about them. So Dr. Spinovitz and Coyne, any comments about this section and anything you want to bring up as a background to introduce your sections better, if you might?
Well, I just want to highlight the issue of iron absorption. You showed a few slides ago the normal patients as ferritin rises, and we know that ferritin's reflecting their iron stores in most cases. Their hepcidin rises, and to protect them against iron overload, their iron absorption from the gut goes down progressively to a very low level in the range of 1 or 2% of available iron in the GI tract. A lot of times, I think nephrologists misinterpret and think that dialysis patients and late-stage CKD patients have malabsorption of iron, and they have normal absorption of iron. The problem is all their ferritins are high. All our patients' ferritins are high, and so are their hepcidins. So they're shutting down that normal iron absorption, as they should, with a high hepcidin level, and consequently, that leads to problems downstream and sets them up to get further iron deficiency.
Thank you.
Yeah, Pablo, I certainly agree. I mean, what you emphasized, and it'll come up when we discuss the HIF-PHIs, is this notion of a coordinated erythropoiesis. You saw in the bone marrow, there's a sequential need for erythropoietin and then iron, and if they're not there at the same time, you just don't get effective erythropoiesis. So it's really the coordination of that, and we try to do it by supplementing, with recombinant ESA and by giving iron. But clearly something that would approach a more physiologic coordinated erythropoiesis with endogenous EPO and mobilization, absorption of iron would be would appear to be a more natural way of correcting anemia. And we'll see how close the HIF-PHIs come to that as we open up that data later.
Okay. So I'm going to address one question that relates to this section, and the question is about if any hyperlipidemia meds affect hepcidin production, and not to my knowledge. I don't think there's any known effect of lipid drugs and hepcidin. We have a couple of questions, one on ferric citrate and one on iron dialysate replacement, that I think will be better addressed after we hear Dr. Coyne's section. So let's again wait to answer those questions after his presentation, and we'll discuss HIF-PHIs after Dr. Spinowitz's section. So I'm going to introduce again Dr. Coyne, who will now talk about a little bit more about iron. So, Bruce.
Oh, Dan.
Sorry, Dan. Sorry.
That's okay. I'll go by Bruce too.
Okay.
That's all right. Sorry.
So in this section, we'll look at implementing evidence-based recommendations for the use of IV iron supplementation and ESAs for anemia in patients with CKD, and that includes both non-dialysis and dialysis patients. To begin, we'll do this survey question. So according to the KDIGO guidelines for iron in patients with dialysis-dependent CKD, which of the following is recommended? IV iron only in patients previously on oral iron, oral or IV iron regardless of ESA therapy, a trial of IV iron regardless of ESA therapy, a trial of oral iron in ESA naive patients only, or I'm not sure. So we'll take a look at the survey questions here. And most of you are not sure, and I'm sure that's a correct answer. And the most, after that, a trial of IV iron regardless of ESA therapy is actually the correct answer. IV iron is essential in the dialysis population. They have higher iron requirements, and oral iron under usual circumstances cannot overcome the high hepcidin inhibition of intestinal iron absorption. There was a question, and we might as well address it now, about ferric citrate. I don't cover that section. Ferric citrate is a phosphate binder. It's an iron-based phosphate binder, and that iron is, to an extent, absorbable. The average person on that binder will be taking in about 2,000 milligrams a day of iron into their GI tract. And it only takes a small amount of iron absorption to give them the equivalent of 4 to 8 milligrams per day of iron. And that's enough to replete their stores in many cases and maintain adequate iron. Still, about a third of those patients will require iron supplementation and potentially higher amounts depending on how adherent the patients are. But in general, the recommendation is to use IV iron regardless of whether or not the patient has ESA therapy if you're a dialysis-dependent population. So the current treatments for anemia in CKD are focused on repleting iron stores, and we need to recognize that the non-dialysis population begin to develop substantial amounts of iron deficiency relatively early in stage 2 and 3 CKD. And this tends to just worsen over time because of impaired absorption of iron from the GI tract for the reasons that have been mentioned, and enhanced losses in part due to our blood drawing and increased intestinal iron losses. ESA therapy is also a major component because we've seen that EPO levels do not increase at the rate they should for the degree of anemia in CKD patients. And then the last problem is we reach for transfusions, which we definitely want to avoid by proper management of the anemia. So some of the potential benefits and risks of IV iron therapy are, first, it's been demonstrated to raise hemoglobins and reduce iron transfusions. It delays ESA therapy, or at least reduces the amount of ESA that is required to be administered to the patients. And it decreases many of the anemia-related symptoms, which are in fact more iron deficiency symptoms per se, rather than directly related to anemia. There are risks with all IV iron agents of anaphylactoid or other acute reactions, so we have to have facilities available to deal with that. They do seem to increase oxidative stress, although the significance of that long term is debatable. And there are other long-term risks that we've never really done very long-term outcome studies looking at many of the endpoints that we like to do with other agents, such as MACE. Although the pivotal trial in particular answers many of those questions in the dialysis population. So we'll cover that in a second here. But first, let's start with the non-dialysis dependent CKD population. So in this trial of 626 CKD patients who were all anemic, they were randomized to either a relatively low dose of IV iron and supplementation later in the year if their ferritins were still low, a relatively high dose of IV iron initially and more supplementation later in the year, or oral iron, which was 100 milligrams twice a day of ferrous sulfate. The standard dose of iron that we give to many patients who have iron deficiency anemia. The oral iron is the orange triangles line here. And you can see that initiation of oral iron therapy in the non-dialysis CKD population increased hemoglobin significantly and was as good as relatively low doses of IV iron, a bit inferior on the speed of correction for individuals who received high dose IV iron therapy and then maintained higher. So oral iron is an option in our CKD population. Many of us have problems using it in our CKD patients because of GI side effects, polypharmacy, and general non-adherence with some of these prescriptions. So you can try oral iron, and if they're failing it or can't tolerate it, certainly IV iron is the way to go to replete their iron stores and improve their anemia and decrease or prevent the need for ESA therapy or transfusions. In the dialysis population, we finally have an outcomes trial of using a low dose as of IV iron and maintaining a low transferrin saturation. The theory behind that was that IV iron is increasing oxidative stress. There's evidence it can injure endothelial cells, and so it might be giving too much of it might injure the patient and cause more cardiovascular events, despite the improvement in anemia. Conversely, we've known for many years that higher doses lower ESA requirements, and higher ESA requirements associate strongly with more cardiovascular events. So pivotal randomized patients to get IV iron every month that their ferritin was under 700 or their TSAT was under 40%. And if they met those criteria, then they would get 400 milligrams of iron that month and have it all repeated the next month. Alternatively, they only got IV iron if their TSAT was under 20% or their ferritin was under 200. So the effect of those two randomization protocols was in the first year, the IV aggressive arm, or what they call proactive iron, received 3.8 grams of IV iron. And you can think of this as loading the patients up with about 2 grams of IV iron and then giving them another 1.8 grams over the course of a year to replace their ongoing losses from hemodialysis. In contrast, the reactive arm just got the 1.8 grams of IV iron, replacing their ongoing losses. After subsequent months and years in the trial, there was actually very little difference between the amount of iron patients got per month between the two arms. The value of loading a patient with IV iron initially in a new dialysis patient is illustrated in these pivotal results, where that proactive iron arm corrected their anemia much more quickly than the reactive arm. And that's shown on the left graphic. That translated into substantially less transfusions in the first year in the proactive iron arm. After that, the rate of transfusions between the two arms was very similar. So you did buy a faster correction of the hemoglobin and less transfusions in the first year of hemodialysis when you're proactive with IV iron. After year one, when both the hemoglobins are similar in the groups, proactive iron leads to less EPO requirements. So the ESA dose was substantially lower, shown in the blue line, in the proactive iron arm. And this allows us to then test whether that may be a driver for increased cardiovascular events. And in fact, it was. So the primary endpoint of this trial was to look at MACE events, major adverse cardiovascular events, heart failure, non-fatal MI, and death. And what they found was the primary efficacy endpoint was met by the proactive iron arm. It was substantially less likely to occur with a hazard ratio of 0.85 and a p-value for superiority of 0.04. You'll notice that the two arms in the trial, the efficacy endpoint shown in the left graphic, don't separate until about 9 months, which is when the EPO doses are starting to separate. Death even separates later, and that's not surprising. And that comes out to about 20 months when there's really substantial difference in ESA requirements. The overall reduction in ESA requirements was about 30% with proactive iron use. And then in an analysis of recurrent MACE events, because you could have a non-fatal MI, you could have another one, you could have a heart failure event, they found that again, the proactive arm led to substantially less events than giving low dose iron. So consequently, the recommendations are to load patients with IV iron, ideally maintain their ferritin at 700 or greater. You probably will need 3 to 4 grams of iron in the first year, but after that, only an average of about 200 milligrams of iron a month to replete or replace their ongoing losses of iron. And so the guideline is that we need to balance the potential benefits of avoiding transfusions. It's notable that these guidelines were written really before the pivotal results were available. A trial of IV iron, regardless of ESA therapy, is indicated in dialysis-dependent patients. In the non-dialysis dependent patients, oral iron or IV iron are reasonable options. Many of us need to reach for IV iron if oral iron fails to accomplish your goals. And lastly, when you're using ESA therapy, you should have already fixed their iron deficiency. And you should be considering that there are other contributors than just ESA deficiency to that anemia, such as inflammation, unrecognized ongoing losses of iron, severe hyperparathyroidism. All of these can be evaluated, and if improved or corrected, can lower the ESA requirements in patients, making it potentially safer for the patients and certainly less expensive for the entire society. So that was the section I wanted to talk on, and I'll be glad to hear what Bruce and Pablo think of that and their own spin on those things.
And thank you for a beautiful presentation. I think this illustrates many, many points that I think our audience should remember from today. One that I want to highlight is that regardless of oral or IV therapy, one must be patient with iron when looking at hemoglobin. So you see in the fine data that Dr. Cohen showed that it takes 4 to 8 weeks to see a significant increase in hemoglobin, and it continues to rise and it starts to plateau week 20, week 24. So do not expect iron replacement to have an immediate effect. you need to understand that this is a medium to long-term treatment that will work, but you just have to insist on it. So short-term oral replacement is not something that will work. And it does, in patients that can tolerate this therapy, show great efficacy. And what I want to bring up is that, again, other than being patient, that as one of the audience members asked about, we do have other somewhat more effective iron preparations that may be better tolerated than ferrous sulfate or ferrous gluconate. So we now have available ferric maltol, is Ferrocru, and as you mentioned before, ferric citrate or Auryxia that may be better tolerated in patients perhaps with constipation or other oral iron intolerance. So do take note of that and look for opportunities to engage with oral replacement. But one thing that I want to ask you, Dan, again, is, again, you made a comment about this chronic long-term risks of IV iron. And from the discussion of the pivotal trial, it seems like there are more benefits than dangers using IV iron at significant doses in the dialysis patients. So can you comment on that? Because I think there's some significant reservation in general from practitioners from using IV iron, perhaps less adequately than we should.
Yeah, I think that the concerns that were raised were based many times on preclinical data or what we call surrogate outcomes and not hard outcomes data. The proactive use of IV iron in pivotal really addresses that issue, and we don't see that long-term problem. It's of note that the average ferritin in the US dialysis population remains and has been since for more than a decade now at about 800 to 900. So it's not like we're using a lot more iron right now than we were in previous years, and we're not seeing those problems. So I think people need to be recognize that while there are these theoretical long-term risks with IV iron, none of it has panned out in trial evidence to date. And in fact, the exact opposite we found, that being iron deficient significantly increases your cardiovascular risk. And that has also been demonstrated in the heart failure population. So in non-dialysis heart failure patients, about half of whom have chronic kidney disease, IV iron therapy is now a standard of care because it reduces the severity and symptoms from heart failure and does not increase long-term cardiovascular risk or death. In fact, in some analyses, it significantly reduces those also.
And importantly, that data was shown even without changing hemoglobin. So it's just, iron is important for energy. Let's not forget that.
Half those heart failure patients were not anemic.
Yes. And the other thing is some of the retrospective data that looked at or suggested the risks of infection actually had a cutoff of 400 milligrams per month. And here, we see the impact occurring at a much lower level. So I think that's important to keep in mind. And I think, you'll see how hard it is to show a safety benefit shortly when I show you some of the HIF data. But, our patients don't get the benefit out of statins. We're unable to show any impact in the end-stage population. Here, this is the first time we've seen a safety benefit from an intervention with a medication. So this is very, very important data.
Yeah, and paradoxically, IV iron of all things.
Yeah.
And also, I think one of the things to emphasize is that some of the older data was based on iron dextran preparations. I understand that depending on where you are, that may be the only thing available, but the newer data is based on the newer preparations with a much better safety profile than dextran. So in my practice, I don't use it. I use Venifer and newer. There is a question here about supplementing IV iron and EPO after dialysis. I'm going to take this. I think EPO and the new iron preparations are not easily removed during the dialysis treatment. Practically giving iron post-dialysis, I think that's very taxing on the process of getting the patient in and out of the clinic. So I don't think that's a practice that would have many advantages. And EPO, frankly, if you have reservations about getting the IV, sub-Q works better. So that would be the way I would address that concern. We had a question about dialysate iron replacement. I think that's a little bit out of our scope. Maybe we can get Dr. Coyne a second to comment on that.
There is a supplement that you can add to the dialysate to provide iron. It probably provides about 10 milligrams every dialysis treatment. And for many patients, that will be enough iron to help maintain their normal hemoglobinization. Whether they need some IV iron supplementation, because maybe that's not quite enough, is in individual patients, but it certainly will reduce their needs. And there is good data that giving a small dose of iron, even IV iron, every single dialysis treatment stimulates erythropoiesis a bit better than intermittent large doses. So it's a legitimate and effective option. It's an elegant way to treat the anemia.
Yeah, and thank you, Dan. A question about coverage. Is IV iron easily covered by insurance if there have been any failed attempts to replace it with oral iron? I'm yet to have any insurance ask me to fail oral iron when I prescribe IV iron. I am not sure what they look at to approve it or not, but I find drugs like Venofer to be very affordable and effective. Of course, you have to give it in multiple doses. As you know, the IV push dosing for Venofer is 200 milligrams. If you're going to give any more, 400 milligrams should be given over 6 hours. But again, one thing to keep in mind is that you should use oral iron first, unless the patient has been proven as intolerant, and you'll know it from your experience with the patient. The anemia is severe, so you want to get iron in their system quicker. They have ongoing GI losses, or again, the hemoglobin is low enough where you think chancing the oral replacement might be something that could fail, and you don't want to go through that step. So again, I do not find coverage as a big issue. Then a question about, can radiation therapy for prostate cancer affect iron absorption? I would say that would depend on the extent of the radiation, but if it did not affect the gut in any way, it's unlikely. But
the iron absorption is in the duodenum.
Right.
So if there's a resection in that, you may significantly impair any iron absorption, and therefore you should reach for IV iron. To the extent that radiation increases inflammation, hepcidin is an inflammatory signal, so it'll increase, hepcidin will increase with inflammation and therefore suppress iron absorption from the GI tract. So if you think that's going on, IV iron makes a lot of sense.
Excellent. So I think it's time to move on to Dr. Svinovich's presentation. He's going to explore the potential role of HIF-PHIs, which again addresses our third objective. We're going to praise the safety and efficacy, as well as the PK and PD profiles of emerging HIF-PHIs and dialysis dependent and non-dialysis dependent patients. So without ado, Dr. Svinovich, please.
Okay, so thanks for that introduction. Let's see, here we have a survey question. So which of the following is associated with HIF-PHI therapy? decreased production of endogenous erythropoietin, increased hepcidin level, reduced hepcidin levels, reduced iron bioavailability, or I'm not sure. I'll give you a few moments. Okay. Well, a good number of you are not sure. Good. So we're gonna see as we go through these slides. But the correct answer was reduced hepcidin levels associated with therapy with HIF-PHI, and we'll see some nuances in actually that answer. So let me move on. So let me just give you a little overview of the HIF pathway. The hypoxia-inducible factor pathway it's a new branch of biology starting in the mid 1990s. Ultimately, the three laboratories responsible for description of the pathway, Semenza, Radcliffe, and Kalin, were the recipients appropriately of the Nobel Prize. And actually, this pathway was really worked out in answer to the question of, how is oxygen sensed and turned into a response with an increase in erythropoietin and hence a increase in red blood cell production. Some of the details were actually worked out in hepatoma cell line. And as you know, in utero, the liver is the main source of erythropoietin, and then upon birth, it shifts to the kidney, although there is some residual ability and production of erythropoietin in the adult from the adult liver. But let's just briefly go over the pathway. The HIF pathway is, as I said, ubiquitous, present in every cell. Hypoxia-inducible factors really are gene regulators, and depending on which organ that cell is in, various things, various genes are turned on in response to an increase in that HIF pathway. And the pathway itself, as you can see, I'll show it here, the HIF is a heterodimer. It consists of an alpha and a beta component. The alpha component is constitutively produced in the cytoplasm, but in the presence of adequate oxygen, since that is one of the main sources of regulation, it is essentially hydroxylated with this pearl hydroxylase domain enzyme. So upon hydroxylation of the alpha component, in this case it's the 2-alpha, that is recognized by the proteasome, degraded, and that is essentially the end of that potential stimulation. But in the presence of less oxygen, whether that be at higher altitude, whether that be in a setting of anemia with its less oxygen content, or in the presence of a prolyl hydroxylase inhibitor, that HIF alpha then moves into the cell, joins with a beta HIF, another regulator, and essentially turns on a number of genes. And the genes in this displayed here are genes that would increase erythropoiesis, that could increase growth of cells, shift from aerobic to anaerobic glycolysis, have significant impact on iron absorption and mobilization, as I'll show you in a moment, and other aspects, again, depending on the cells involved. But in our instance, we're concerned about erythropoiesis. And so, again, whether it's high altitude, anemia, or the presence of a pearl hydroxylase inhibitor, there will be increased erythropoiesis. As was mentioned earlier, and I'll go through this slide rather quickly, there are a number of other impacts of HIF stabilization, if you will, in the presence of a pearl hydroxylase inhibitor or in the presence of a lower oxygen content. And those impacts are essentially the effects on iron absorption through the gut and iron mobilization from macrophages. One of the main mechanisms by which that occur is that with increased erythropoiesis, in the presence of a HIF, a PHI, erythropoietin is released from the bone marrow, and that would decrease hepcidin. With less hepcidin, the ferroportin is available to move iron out of the intestine or move it out of the macrophage. But in addition to which, HIF stimulation also has direct impact on many of the enzymes that are involved with iron absorption in the duodenum, as well as iron transport to the marrow or to the storage facility. So HIF PHIs are uniquely able to create this setting for this coordinated erythropoiesis with increased erythropoietin as well as increased iron availability. I would quickly point out that the increase in erythropoietin subsequent to intake of a prolyl hydroxylase inhibitor is rather minimal. Depending on the drug, the increase in erythropoietin is anywhere from 2 to perhaps 3 or 4 times basal levels. This is in contrast to when we give exogenous recombinant human erythropoietin intravenously. The erythropoietin level transiently is in the 1,000 range, in much higher multiples of the basal level of 10 to 20. Even sub-Q administration has EPO levels that are in excess of the impact on the bone marrow. So what you see with the HIF PHIs is a very small, relatively small increase in erythropoietin. It's transient, depending on which compound. The EPO levels are back down to baseline at 24 to 48 hours. So the pharmacokinetics of the HIF PHIs are very interesting. They have some different half-lives, but obviously the pharmacodynamic impact, that is to say the increase in hemoglobin, is what we're looking at. But the minimal increase in erythropoietin is an important feature of the HIF PHIs. So the current status of the development, there are at least 6 that are in various stages, some completed of evaluation. Roxadustat is currently approved, as you see, in Pacific Rim and in a number of other countries. It has already undergone FDA evaluation, and they voted against approval due to safety issues. We'll go over those in a moment. Some additional clinical trial on safety in both non-dialysis and dialysis was requested by the FDA with respect to VITADU. It's currently approved in Japan. It is coming up for FDA evaluation at the end of March. And daprodustat, again, currently approved in Japan, and it will be likely reviewed by the FDA late 2022, early 2023. So that's where we stand. Those are the 3 that are furthest along. Shown here, there's a lot of data, just a list of the studies that have been completed with respect to the DUSTATs in terms of impact on anemia. And I show this for a number of reasons. Mostly, when you just take a look at the number of subjects and just eyeball the numbers, we're looking at 20,000+ patients that will have been evaluated with the HIF PHIs in the various studies. With respect to roxadustat, there were 3 studies, each in non-dialysis and 3 in dialysis, that formed the core of the data that was presented to the FDA. Uniquely, in the non-dialysis roxa trials, it was the investigative drug roxadustat versus placebo. All the other studies were the DUSTATs, whether it's VITADU or daprodustat, against active control, that is to say, an active erythropoietic agent. So let's take a look at some of this data. We'll review the efficacy first and have a discussion, and then go over the safety data. So the efficacy data was hemoglobin efficacy either versus placebo, as I told you, for roxadustat, but for most of the studies, it was against active control and active ESA. And with respect to comparisons, when it was efficacy against an active erythropoietic agent, it was for non-inferiority. Against placebo, it was for superiority of efficacy. And additional data was gathered regarding transfusion reduction as a possible benefit as an efficacy endpoint, as well as the avoidance other salvage therapies, such as use of IV iron or an ESA as a salvage for a patient that wasn't responding to the HIF-PHI. So those were the main efficacy endpoints. So let's take a look at roxadustat. So here, as I mentioned, this is a composite of the studies for efficacy in the non-dialysis population. As I told you, was roxadustat versus placebo. The reason they chose placebo in this setting was the contention that, in fact, many, actually the majority, more than 50% of patients prior to dialysis are not treated with an ESA, are not treated with significant IV iron supplementation. And so they felt that a comparison to placebo was a reasonable, that even though it may not be standard of care, but it was de facto standard of care. So they looked at, again, this is approaching almost 4,000 patients who were randomized in a, this was a blinded placebo-controlled study with the intent of achieving a hemoglobin of 11 plus or minus 1. So the range was 10 to 12. Patients were dosed based on weight. There were 2 dosing levels, above and below 70 kilos. And as you can see, significant, fairly rapid increase in the hemoglobin noted. Placebo minimal increase. The difference was 1.7 grams over the evaluation period with respect to efficacy, the 28 to 52 week period of time shown here. There was a diminution in the hemoglobin with adjustment of dose, and so clear superiority with respect to efficacy with respect to roxadustat. Here is the roxadustat in one of the studies in the dialysis population. Here it was roxadustat against the Erythropoiesis alpha, open label. This was not a double dummy blinded control, so everybody knew what they were getting. That conceivably could have had some impact in terms of adverse events experience. But as you can see, this is in the incident dialysis population, a fairly large portion of the total dialysis population studied. And you can see that roxadustat, a small increase perhaps relative to Erythropoiesis alpha, but basically a comparable response. And this was pretty much the same as what was seen for the entire dialysis population, shown here, roxadustat versus Erythropoiesis alpha. A small difference, and certainly that difference of 0.26 was well above what would have been the inferiority level. And so in this active control study dialysis population with roxadustat, there was a non-inferiority with respect to outcome. In terms of some of the subsequent or other impacts that were alluded to based on the pathophysiology that Dr. Pergola and I alluded to. The impacts on hepcidin, you can see this is the non-dialysis population, so it's against placebo. Significant decreases in hepcidin, which were predicted based on the increase of erythropoiesis, presumably indirectly via that increase in erythropoietin. With a decrease in hepcidin, there was mobilization of iron, evident by a decrease in ferritin in the roxadustat treated patients. There was an increase in the iron level, again, presumably due to increased mobilization and absorption. The impact on saturation was variable, basically because in addition to an increase in iron and a decrease in ferritin, we actually saw an increase in the total iron binding capacity, another impact of the HIF-PHIs. So all in all, total evidence of benefits on the iron side of erythropoiesis. Here it's interesting, the roxadustat patient population, again, non-dialysis, the entry criteria were a little more relaxed than in some of the other HIF-PHI studies. So patients were allowed into the study if ferritins were down to 40 and TSATs, depending on the study, anywhere from 5 to 15% TSATs. Despite that, about 60% of the patients were iron replete in the non-dialysis population. By definition, ferritins 100 or greater, TSATs 20% or greater. And what you can see, however, is this interesting impact of the HIF-PHIs, that whether the patient came into the study iron replete, as I just mentioned, or iron non-replete, somewhat lower baseline iron parameters, you can see the impact of roxadustat was comparable in terms of increasing hemoglobin, again suggesting that the HIF-PHIs are beneficial not only in terms of increasing erythropoietin endogenously, and in turn increasing hemoglobin production, but in having this coordinated erythropoiesis with the enhanced availability of iron from stores as well as from the gut. One other interesting aspect is they looked at the impact on hemoglobin in patients with high CRPs. Again, the non-dialysis population, elevated CRP is a surrogate marker for the inflamed state, if you will. And you can see that compared to placebo, again, you can see that 1.7 gram increase, very comparable in this more quote unquote inflamed population with a high CRP, again, suggesting that the HIF-PHIs can perhaps bypass the inflammatory suppressors of red cell production. But we'll come back to this point a bit in the discussion. They also showed decreased transfusion requirements in the non-dialysis population treated versus a placebo. So let me go on to the VITADU data. VITADU had two large studies in the non-dialysis population, an EPO-naive and an EPO-treated group. And that is to say, the treatment was either for correction in the EPO-naive or conversion in the patients who were established on EPO, randomized 1-to-1. All these patients were treated with VITADU starting those 300 milligrams. I would point out here that VITADU as well as daprodustat are once-a-day dosing, shorter half-lives, as opposed to roxadustat, which is a 3 times a week dosing HIF-PHI. Patients could be titrated up or down accordingly. Darbepoetin was given subcutaneously or IV in these patients. And the primary efficacy period, there were 2 efficacy evaluation periods, week 24 to 36, week 40 to 52, and then these patients continued on for long-term safety data, as was the case, I would point out, in the roxadustat. So the safety patients, for safety, data continued beyond 52 weeks. Efficacy was typically assessed in periods in the first year. And here we can see the data in the ESA untreated as well as the ESA treated. And you can see in, I guess it's a bluish green, VITADU, a slight lag behind darbepoetin, but certainly in the evaluation periods right around here, you can see that the impact is comparable in terms of change of hemoglobin. Here, the dosing was 10 to 11 for patients in the US. In the non-US, it was 10 to 12, consistent with the recommendations in the non-US geographic regions. In the ESA treated, that is to say, these were patients who were converted to VITADU. You can see a slight lag early on, but again, in the critical part in terms of the primary and secondary efficacy periods, ESA, VITADU comparable, essentially non-inferior to the darbepoetin treated patients. And here's the data in the dialysis population with VITADU, again, dosed on a daily basis. There were a somewhat smaller incident, EPO-naive population that was looked at in one study. Most of the data was in the prevalent for maintenance of hemoglobin. And you can see, and this is probably a choice of the dose, but there's this slight lag in the VITADU with respect to, in this case, the ESA comparator. For the prevalent patients, again, a slight dip, but in the period of time where the patients are analyzed for the primary endpoint, the hemoglobins essentially are comparable, showing non-inferiority again for VITADU in the dialysis population. And the daprodustat studies, again, two large studies, one in non-dialysis, and you'll see the dialysis data in a moment. Patients were randomized to daprodustat, and again, the endpoint was hemoglobin 10 to 11. Patients were titrated. The evaluation period was weeks 28 through 52. And then again, patients continued on for safety data. And you can see, again, the response curves of the darbepoetin versus daprodustat for the evaluation period are almost superimposable. This in the non-dialysis population. And the study design in the dialysis population was comparable, but just to show you the data, again, in terms of efficacy in these patients, there was comparable response, daprodustat versus ESA. So in summary, the efficacy of the HIF-PHIs is that they clearly all do increase hemoglobin similar to ESAs, that in the one case, roxadustat superior to placebo. There may have been some dosing regimen changes from phase 2 to phase 3 that may have accounted for some of the minimal efficacy differences. And the impact on that, as we'll discuss when we get to safety, there may have been some impact in terms of safety outcomes, particularly with respect to roxadustat. There were certainly suggestions, if not absolute data, to support that the HIF-PHIs do have a beneficial impact on iron in terms of increasing transferrin levels and indicating that there was increased iron absorption and increased availability. And that there's certainly a suggestion that there's an iron sparing effect. We can discuss that shortly, whether the data truly supports an iron sparing effect of the HIF-PHIs. And again, the data that I showed you with respect to roxadustat in terms of whether the HIF-PHIs are more effective in the inflamed patient, what we might call the ESA hypo-responding patient. While the data is suggestive, it may not be as convincing as we'd like it to be. So with that, I'll stop for a moment and open it up to comments and perhaps some questions from the audience with respect to efficacy. So Pablo?
Yes, thanks, Bruce. That was excellent summary of a lot of data. I mean, I want the audience to appreciate that it's very difficult to summarize dozens of studies in 20,000 plus patients the way you masterfully did that. So appreciate that. I think some of the questions you've already addressed. One was related to head-to-head VITADU versus darbepoetin. I think that was already shown clearly in the data. The question is regarding daprodustat IV versus or oral daprodustat, and the dustats are all oral preparations. So there are no IV preparations that I'm aware of. And in fact, the advantage of these agents over current preparations is the fact that they're oral and can be available to patients that are not on dialysis or they're on home dialysis. So that's important.
Pablo, can I just throw in, there's one point that I failed to point out when I was going over the pathway, is that the reason the HIF-PHIs are orally effective is because we're blocking an enzyme. We're blocking that perolyl hydroxylase enzyme. And so the ability, you don't need a protein, you just need a molecule that approaches the proximity of the binding site on the HIF alpha that blocks that PHI, and hence their oral compounds.
Yes. So there is a question about the efficacy of these drugs, of the oral similar to injectable. And I think, again, it was shown very clearly and all of these agents are efficacious at increasing hemoglobin. And one of the things that I think the audience must be aware of is that The rate of increase in hemoglobin and the achieved goal depends a lot on the dosing regimen selected by the investigators. So you can have hemoglobin go much higher or lower depending on how much you give. And I think it was mentioned that one of the studies, roxadustat, was dosed based on a kilogram per dose type thing. So again, whether you decide to give more or less to smaller or bigger patients or start with a higher dose when the hemoglobin is lower, all that affect the rate of rise and the achieved goal. So I think all these drugs are efficacious enough that minor differences in study design can reflect the achieved hemoglobin. So I think they all are effective at increasing hemoglobin, and their efficacy is similar to the IV drugs. Bruce, the question is, in VITADU studies, was the hemoglobin increase in shorter time interval in NDD, CKD patients? Perhaps you can answer this one for us.
So I'm not sure I'm getting the, what did it seem to be a faster rate of rise?
Yes.
Yeah. As you alluded to, the dose response curves really were worked out very carefully in the phase 2 trials. Obviously, we don't have time to have gone over all that, but the impact. The dose chosen in VITADU was actually somewhat lower than what we might have concluded, and there were some reasonable reasons for the choice of the 300 milligram. But I think the change, the rate of rise and differences between the NDD and the DD may have been reflective of the patient population. But as you pointed out, there clearly is a dose response curve with these compounds. For example, the roxadustat. The dosing was for the 70 kilo person, which was the average weight of these individuals, was the 70 milligram, just about a milligram per kilo. And that was a dose that in phase 2 actually led to a slighter, faster rate of rise. Patients given 0.7 per kilo had a slower rate of rise of hemoglobin. So really, the trials were designed, doses were chosen by the sponsors, and that clearly had an impact on the rates of rise, and as we'll see, perhaps even some of the safety data. I would throw one question towards Dan's way, and that is, what's missing from these efficacy data with respect to, for example, treatment of the hyporesponder or definitive evidence on improvement of iron absorption? Dan, any thoughts?
Well, I mean, the large trials really focused on the final endpoint that we care about, which is MACE outcomes and the safety of these agents, and secondarily, the change in hemoglobin. So it's very hard to do trials in EPO-hypo responders. Patients either get better faster than you can screen them into the study, or they're so sick that they can't enter and they die. While there's a lot of signals that these agents are particularly efficacious in that population, proving that in a trial setting is very difficult.
Yeah, I agree. I think we've all been the clinical trialists with these, and we've tried this with other ESAs, and it's very, very difficult to get a true consistent hyporesponder, and many of them, it may be a marrow problem rather than an erythropoietin problem. So I think in the interest of time, I'll move on to safety because that's quite important. So what's shown here is an overview of safety. So all the studies were pretty much the same in terms of the primary outcome for safety, and that was MACE, major atherosclerotic cardiovascular events. But in fact, the endpoint was all-cause mortality. Granted, in most of the studies, that was 50 to 60% or so of all the mortality was cardiovascular in nature, but it really was all-cause mortality, and then a non-lethal MI and a non-lethal stroke. So those are the three major components that were the primary outcome. And these were non-inferiority studies that were designed to show, again, not to show that the DUSTATs were, in fact, no less safe, if you will, than the comparator. With respect to Roxa in the NDD, it was against placebo. For everything else, it was, for all the other studies, it was against an active comparator. And what is required by the agencies is to show in a primary analysis that the hazard ratio does not have an upper bound greater than a certain number. And the number that was chosen pretty much was 1.25. That's to say that the active comparator confidence interval upper limb was no greater than 25% worse. And that's the primary analysis. And here you'll see primary versus sensitivity analysis. And the agencies very often, certainly the FDA, for non-inferiority trials, is clear in stating that they want a primary analysis, which may be on study. That is to say, you look at your whole patient population. Now, over the course of many years, you have patients in this instance that may be dropping out from the active limb of the study. They may be moving on to dialysis. If they drop out, very often they will then be shifted onto an active erythropoietic agent for salvage, if you will. But they are still counted as in the group that was part of the investigational product, and they are considered on study. Another analysis is to say, well, as soon as the patient stops therapy, we'll consider looking for one of these events up to a certain point. And that would be called an on treatment. And it's typically on treatment plus a certain number of days. By and large, it was 28 days. If someone's on an investigational product and the half-life of that product is hours, and within 5 half-lives, a few days, the product is out of their system, well, you can stop analyzing for that outcome perhaps days after they stop treatment. But, we're dealing with erythropoietic agents that have a pharmacodynamic impact that lasts a lot longer. So the sensitivity analysis that the FDA requires is an on treatment plus some period of time. In this case, as I said, mostly 28 days. So just take a look at the primary analysis for the various compounds. And let's go backwards from roxadustat through VADA and then dapro. And you can see what's listed in red is when the upper limb exceeds what the FDA thought was reasonable in terms of non-inferiority. So with respect to the NDD study, the hazard ratio was 10% worse than the comparator. There was a range of the confidence interval, but it hit 1.27. The sponsors stated that the upper limb that they had agreed to was 1.3. There was some controversy if you read the FDA documents, and it's listed in red here because that was part of why the FDA said no. And in addition to which, the sensitivity analysis looking at an on treatment plus 7 days, which is what the FDA chose to look at, had the hazard ratios even worse. With respect to the dialysis population with roxadustat, the upper limb did not exceed the 1.25. And here the analysis, because there were fewer dropouts, it was an on treatment plus 7. The sensitivity analysis exceeded the FDA's upper limit, and therefore it's shown in red. That, along with some side effects that we'll discuss shortly, probably contributed to the FDA's rejecting roxadustat for approval. With respect to VITADU, we now have the data that was published in the non-dialysis population. The MACE hazard ratio was 1.17, but the upper limb of the confidence the upper bound was 1.36, in excess of what the FDA had agreed to of 1.25. As I show you here in red, we'll see what the FDA has to say, and I'll show you some nuances of that data in a moment. But as of just this, analysis, they did exceed and was not deemed to be non-inferior. With respect to dialysis, no problem, hazard ratio of 0.96 with the upper bound well below the 1.25 shown in black. There's no reporting of a sensitivity analysis. We'll see if the FDA generates their own at that PDUFA date at the end of March. And then the published the Protostat data, non-dialysis 1.03, the upper limb does not exceed the 1.25, but the sensitivity analysis and on treatment plus 28 days did exceed that, shown in red. We'll see again the end of 2022 what the FDA has to say about it. And with respect to dialysis, certainly non-inferiority in both the primary analysis and the on treatment plus 28. As you can see, the upper bound does not exceed that 1.25. So black across for dialysis. Let's take a look at some of, and I want to be mindful of time and have a little time for discussion. So one of the problems that the roxadustat study encountered is it was, as I mentioned, for non-dialysis, they evaluated roxadustat versus a placebo. And as a consequence, you've got significant dropout. So by 52 weeks of 1 year, you've got almost half of the patients in the placebo dropping out. Well, who are those patients? They were presumably the most anemic, probably the lowest GFRs, and they then move on to perhaps another ESA. And you can see this differential dropout, this differential exposure creates significant problems in terms of analysis. I would say in general, by the way, with all the DUSTAT studies that I've alluded to, the mean GFRs was just about short of 20 cc estimated GFR. Compare that with Choir and Treat, other studies of ESAs for, again, studied for different endpoints, if you will, but the data that we have from those studies, the mean GFRs then were in the high 20s to the mid 30s. So in general, all the DUSTATs evaluated patients in the non-dialysis arena with much more further advancement of their CKD. But this differential dropout creates significant problems with respect to the analysis for roxadustat. Because the patients on roxadustat stay in the study. Many of them move on to dialysis. They have progressively decreasing GFR, and the placebo, certainly with respect to on treatment, the placebo patients have dropped out. And so you have a very differential exposure, and that leads to a different endpoint in terms of hazard ratios. And it is in this arena, this on treatment plus 7-day analysis, that the FDA held roxadustat to with a much higher upper limb domain of the confidence interval, led the FDA to reject roxadustat in that setting. And then with respect to safety, this may be a little too small to see, but there were issues of serious adverse events as well as adverse events in both the non-dialysis and the dialysis population with respect to increased evidences of thrombosis. And in dialysis, we were talking about DVTs and pulmonary emboli. There was a higher incidence of serious infections. There were higher incidences of seizures in the patients who received roxadustat. And these are all warning signals that are in the current ESA package insert. But the FDA on that basis rejected not only in the non-dialysis population, but in the dialysis population as well. There was a correlation to a certain extent in the thrombotic event AEs in the non-dialysis population with rate of rise. As you saw, the rate of rise in with Roxa, perhaps because of the dose choice, was a little quicker than one might like with treatment with an ESA, and that may have correlated, that seems to correlate with some of the thrombotic events. And in fact, Roxa did make a proposal which was rejected by the FDA for approval, albeit at a lower starting dose. You can see here the 70 milligram for the starting dose for the patient 70 kilos or less. The suggestion was, well, perhaps we'll start at 40, but the FDA's tasked the sponsor with going back and doing that study rather than just making a proposed dosing change. With respect to VITADU MACE events, as I showed you in the chart, the upper bound of the confidence interval in the non-dialysis population exceeded the 1.25. We'll see what the FDA has to say about that. The sponsor did make a distinction between the US and the non-US population. There was less of a hazard in the US population where the hemoglobin endpoint was 10 to 11, in contrast to the non-US where it was 10 to 12, although both geographic regions were randomized. And in a subsequent analysis of all-cause mortality, one of the components of MACE, when they make an analysis with age as a continuous rather than a dichotomous variable, in the original statistical plan, it was to look at age above and below 65 as a strict cutoff. It's more appropriate to look at age as a continuous variable. And when you look at the all-cause mortality, US, with that adjustment for age as a continuous variable, you can see that the upper bound of the confidence interval is well below the 1.25, but it remains to be seen what the FDA has to say about that particular analysis. With respect to the dialysis population, VITADU, no question, this MACE event line is bang on, superimposable, and you can see the confidence interval 0.96 with the upper bound well below the 1.25. So there's no question about the safety. Yes.
To interrupt, perhaps you can give us moving on to DAPRO, just an
sure. Just let me
bird's eye view on this.
Yep. Just quick for DAPRO primary analysis. Again, in the non-dialysis population, the MACE is, again, superimposable. Upper limb does not exceed 1.25. There is some issue about the secondary analysis, which I don't think we have time to evaluate. And the MACE data in the dialysis population, again, you can see the hazard ratio, DAPRO versus ESA, 0.93 with the upper bound 1.07, well below the FDA's criteria. The issues, there were some issues raised with the Produstat in the non-dialysis population, a slightly higher incidence of cancer-related death and tumor progression, as well as some increased esophageal and gastric erosions. It remains to be seen what the FDA has to say about that particular safety event in the non-dialysis population. So all the HIP PHIs are efficacious for correcting anemia. They're not identical in action. Slightly differences off-target effects and different safety profiles that maybe raising hemoglobin not to exceed 11 in a slow increase to avoid thrombotic events. That seems to be a good idea. We've functioned under that mantra, and maybe that was some of the issue with Roxa. And compared to placebo, the HIP PHIs may increase some cardiovascular risk, but those warnings are in the label right now. And there is an issue with VITADU with respect to the non-dialysis population. We'll see what the FDA has to say about the all-cause mortality US data. Long-term safety data, we have a lot of data on, as I said, 20, 30,000 patients for 2.5 to 4 years, but we may want longer-term safety data with respect to the HIP PHIs. And HIP PHIs have been approved in a number of countries, and we're waiting to see what the FDA has to say about the other 2 HIP PHIs that will come before them over the next months to a year. So I'll stop here in a few minutes, I guess, for questions and open up to safety. Sorry for going on, but it's a lot of data.
So thanks again for extremely insightful analysis, Bruce, of a lot of data, and I think the audience appreciates this detail. I think we're going to move on to the last portion so we can address some of the questions. So I really thank you, Dan and Bruce, for your excellent presentations and clinical perspectives. By way of summary, I'd like to offer a few SMART goals, which are specific measurable, attainable, relevant, and timely action items that include recognized signs and symptoms of anemia in patients with CKD, implement current guidelines for optimizing management of anemia by addressing decreased availability of iron and decreased levels of erythropoietin, and lastly, stay current with new developments regarding the use of HIP-PHIs for dialysis-dependent and non-dialysis-dependent CKD. So we're going to move on to the question and answer portion of this activity. As you already know, you can submit your comments and questions by selecting the Ask Question tab below the slide viewer. You can also email us at questions@cmeoutfitters.com or tweet to CME So we have a few questions, and I'm trying to address some. There are many that I think were very nicely addressed by the presentation. I think several relate to safety, which I think was covered really well. I think some of the questions are a bit more overviews that I think are probably adequate to address, and that's, what is the population that would be most adequate to use the HIP-PHIs, and do we think we're going to have a choice in whether we use the traditional treatment of iron plus EPO and perhaps iron plus HIF? So maybe we'll start with Dan, and then Bruce, you can comment.
We were hoping that there'd be better safety with these and they would replace ESAs, and that's clearly not what came out of the safety data. So I think initially they'll get introduced just like a new drug of comparable safety, which is they'll get an incremental use in people who aren't doing real well on our present therapy, in particular higher ESA doses and those who aren't at hemoglobin target on relatively high ESA doses. As people get more comfortable with them, maybe that'll expand. In the non-dialysis population, people who have trouble getting in to get intermittent shots, or we can't write them and teach them how to give shots at home, this represents a great opportunity to treat those patients and expand treatment of anemia in the non-dialysis CKD population.
Thank you.
Yeah, I tend to agree with the populations that would most benefit. And I think basically as a nephrologist, physician, I think the important thing is to have all this data out there, to have this class of compounds, some of these drugs in this class of compounds at our disposal, since there clearly are some patients who would benefit from an orally administered ESA that clearly works, and we would have to be cautious based on the safety data that has been adequately accumulated to date.
Well, thank you for that excellent summary. So fortunately, we're just about out of time. I'd like to again thank my colleagues, Dr. Coyne and Spinovitz, for an excellent presentation and a very enriching discussion. And thank your audience for your participation and attention. To find out about CME Outfitters' upcoming events and view previous ones, please visit the CMO Virtual Education Hub of the link here. To receive credit, CME and CE credit for today's program, complete the post-test and evaluation. You will be able to download and print your certificate immediately upon completion. And we all wish you a very